Hello, everyone, and thank you for tuning in to the HPHR Journal Insights podcast. HPHR Journal is an independent academic referred journal that seeks to improve health equity and social justice through the publication of content grounded in the thoughtful evaluation of evidence. It is published by the Boston Congress of Public Health, a nonprofit organization that addresses social change at the nexus of public health, health equity, and social justice. This podcast delves into articles published in the HPHR Journal that addresses complex public health issues in an effort to affect social change. My name is Riva Bajuri, and I will be your host. Today, I'm joined by Kirti Harish, co-author of Caution is Required When Clinically Implementing AI Models, What the COVID-19 Pandemic Has Taught Us About Regulation and Validation. His article can be found in HPHR Journal, edition 45 on artificial intelligence, available on hphr.org. Please introduce yourself, your professional background, and the content of your research.
Thanks for having me, Riva. My name is Kirti Harish. I'm an MD MBA student at NYU, currently in my fourth of 5 years. I studied public health as an undergraduate, and at the time, I became involved in a few different interesting activities, including being part of a health insurance startup that piqued my interest in health systems. And so when I entered medical school, I knew that artificial intelligence was one area that I wanted to explore from a systems perspective, particularly the regulatory environment. And that's sort of how I got drawn into the work going on at NYU in artificial intelligence. This paper specifically deals with the pearls and the pitfalls of using machine learning in clinical environments and the gap between translating what happens in code to what happens in the hospital. Machine
Fascinating.
learning,
Thank you so much. And I was wondering, why did you choose this research topic?
the genesis of this came about because the beginning of COVID was scary for a number of reasons, not least being that um, there was really no clinical mental model for COVID among those who are working on the front lines. And so, for instance, when you think of having a cold, you know a lot about it, not even being a healthcare professional. You know that you have a cough and you're tired for a few days. It occurs relatively randomly. There's no real treatment, there's no real prevention, and you don't really have any long-term effects afterwards. None of these questions were answered when it came to the beginning of COVID. And so we had a number of data scientists publishing, sort of joining the cause at the start of COVID. Over 100 articles were published over the course of 2020, and given the information gap that was present in healthcare facilities at the time, there was a very real probability that these published models would be used in a clinical context, and that's where we got the idea of exploring what it would take to get these ideas from published computer science or machine learning work into a clinical setting reasonably and for the benefit of patients.
Thank you. And can you discuss some of the literature that has inspired your research, and what were some surprising results of your literature review?
Definitely. So, as I mentioned, over 100 articles were published in 2020 that dealt with machine learning models centered about COVID, one of which was actually published from our team at NYU. We built and tested a machine learning model. It was trained on over 3,000 patients and tested on about 500 patients. And then it actually went live. And we found that other places had also published their own machine learning models that they had built and tested. And so we were curious how those performed on our patients. And so one of the studies we did as a precursor to this paper was we looked at 10 other models that were published in the literature, and we used those machine learning algorithms on patients who had come to NYU. So at that point, the facility had treated over 4,500 patients for COVID. And so by running those patients through these algorithms, we assessed how well they worked. And we found that none of these algorithms worked as well as was advertised in their paper. Not because these researchers were lying or did poor job, but because people hadn't really considered the implications of using these models on patients outside of the limited circumstances that they were trained upon. And so that sort of constellation of findings is what brought us to this paper, which discussed why that might not be the case.
How can we prevent suboptimal data utilization, and how will doing so improve AI models?
So, of course, when it comes to these artificial intelligence models, they're only as good as the data used to train them. And so the two issues that we come across are one, what choice was made of which data to use, um, and the second is, how was this data collected? And so, in answering the first question, we actually looked at something called the Epic Deterioration Index, which is a machine learning model that was already in existence prior to COVID. It was never trained on COVID patients. It was largely used in ICU settings to predict unexpected death. And we found that over 100 hospitals were using this model to predict what would happen to COVID patients. And as you can imagine, there were gaps in how well that model performed, and it was, being used in actual clinical settings. The second problem is, of course, how this data is collected and what differences there might be um, between settings in which data is used. And so, for example, when we were looking at other models and how well they worked on our patients, we found that consistently models from China were not performing up to par. And when we took a closer look, we actually found that it was because certain lab measurements in China are measured in different units from the way that they're measured in the United States. And so, uh, as a result, their models didn't perform because we were using poor data and not calibrating it to what we needed to do. And so, kind of as a general rule of thumb, if you use poor data to construct your model, you're going to come out with a poor outcome, and that's not something that kind of anybody wants.
Of course, definitely. And kind of going off of that, what are the consequences of assessing AI models based on how well they predict retrospective data?
This issue can be a little bit nuanced, but in general, retrospective data or data that has already been collected is generally used to train AI models, and then prospective data or data that the model has not seen is used to test how well these models work. And so it kind of works like teaching a child um, some basic concepts. So, for instance, if you point to a red bike and say that's red, and you point to a blue car and say that's blue, and then you show the child a red bike and a blue car, it can probably identify which one's red and which one's blue. But then, if you give it new information, for instance, if you switch them and show the kid a blue bike and a red car, then you really find out whether the child understood the difference between colors or between vehicles. And so, in the same sense, when you use retrospective data to test these models, you don't know whether these models just memorized and drew connections among what it's already seen or whether it can handle new problems to come, which would be most or closest to what it would see in a clinical situation.
Definitely. I appreciate that kind of simile to put that all into perspective. Um, my next question is, how can we optimize applicability of AI models across populations?
Yeah, healthcare unfortunately um, it doesn't have lab grown data. And so there's this basic heterogeneity that exists both across space in different geographic regions, for instance, in different populations, and across time. And so the issue that came across with COVID was that this was a global phenomenon. And so the same disease was affecting many different populations across the world. And so you couldn't necessarily take by virtue of common sense, you couldn't necessarily take a model that was developed in New York City, for instance, and expect it to work the same exact way in Munich or Shanghai, because these are different groups of people. It could be genetic differences, it could be differences in comorbidity like obesity or smoking. It could be differences in the healthcare system, how quickly people present to the hospital, where they present. Is it their doctor's office? Is it an emergency room? That kind of situation. And then you also have this difference over time. And the biggest, uh, most glaring example of that is in treatments. And so, for instance, if you were to take a model that was developed in the beginning of 2020 and try it now, you would have the complicating factor of the new treatments that have been developed for COVID, and those models wouldn't quite know what to do with them. And so, understanding that um, those changes that occur is crucial to understanding how applicable these models are. And so, you kind of have to know how the model was built in order to know how you can use it.
Definitely. And how might inadequate AI models contribute to misinformation regarding healthcare disparities?
So, like we alluded to earlier, if you put garbage in, you get garbage out with these models. And so there are a couple of different ways that can go wrong with regard to healthcare disparities and with regard to equity. One of which is the quality of the data that was collected. And so, for example, there's a well-known instance of a healthcare disparity issue in lab testing, and that's in kidney function. Uh, Based on historical precedent, there is a different measurement or a different conversion factor when it comes to kidney function measures between African American patients and the rest of the population. And so we know that those have not quite borne out, those differences have not quite borne out in the ways that they were expected to in the past. And so if you use a measure like that that's innately biased, the model that comes out of it that's been trained on that data is also going to be innately biased. And so one of the other examples here is that of access. And so you have to understand who is included in the models that you're training and who's not included, and how that might make a difference. For example, if you use a model training people on COVID-19 in hospitals, you are implicitly including only those individuals who had access to hospitals at the time. One of the biggest examples throughout history of this is throughout drug trials, women were historically excluded. And so then when you create a model that takes into account information from these studies, you have a representation problem that carries biases into the final product.
Definitely. And kind of going off of that question, how carefully and thoughtfully implemented AI models promote health equity and social justice?
Speaking of access, I think artificial intelligence, these sorts of machine learning models have great potential to expand um, care in general and who's able to receive care. And one of the examples that we see, and I have not used this and I haven't studied this, so I can't advocate for or against it. But Warby Parker, the eyeglass company, has a machine learning model that takes into account somebody's prescription, tells them whether that model thinks it's changed or not. And that is, of course, great for Warby Parker's customers, but it's also great for somebody who doesn't, within a reasonable radius, have an optometrist or an ophthalmologist to go to. And in those sorts of settings, we can expand the reach of medicine beyond where people can go, and get patients the help they need. Now, of course, the flip side of that is we then have to be careful to delineate what can be done by humans and what can be done by machines, and that's going to create a slew of kind of policy um, and private sector issues to come. But I think the basic tenet is that we can expand care beyond the people who are receiving it in the present day.
Definitely. And so, what would your call to action be for the audience, anyone listening to this podcast right now?
Healthcare, as it stands right now and at the pace that it's growing, has something that I would call a last mile problem. And this last mile problem has been used to kind of grow the industry of e-scooters and bike sharing and that sort of um, those sorts of solutions. But the basic idea is that you can plan your trip very well. You pack your bags and then you take your bus, your plane, your train, whatever it is, and you get off, and you're still not quite at your destination. There's still that last mile to go, and you need to figure that last part of your journey out. And in healthcare, the way that this presents itself is that we have, fortunately, so many smart people working on issues in healthcare, whether they're bench scientists, computer scientists, social scientists, policy wonks, whoever it might be, that are coming up with innovations that have the potential to change lives. And it's the goal of people who are in these fields or who understand multiple sides of issues, who speak multiple languages, to try and take these solutions and plug them into kind of the complex tangle that is healthcare. And once we're able to take these solutions and plug them into the system, then we're able to create change and maximize the potential of the work that all these people are doing. And so the call to action would be to think more about not just what the solutions look like, but how those solutions can be implemented, how we can plug those in and make the best use of all the work that's going on around us.
Wow, thank you very much. Those are all of my questions, but I was wondering if you had any last comments regarding your research that you would like to share.
The only last comment that I have is I'm happy to speak with anybody who may also be interested in this area or other students who may want to learn more. Please feel free to share my contact.
Of course, definitely. I will definitely link that to this. But thank you so much for coming on to the HPHR Journal Insights podcast. Um, yeah, have a nice day.
It's been a pleasure. Thanks again, Riva.